Hello, hello, hello. As mentioned in 5 minutes ago, Girish and Dr. Jeremy, we have about 200 people that signed up for this session today. So there's a lot of interest in how WelbeHealth is approaching scaling excellence. So thank you for making time with us today. While we wait for people to trickle in, maybe a very easy question that we ask all people that we interview. Maybe starting with you, Jeremy, what is the book that you recommended most to other people? And maybe while you answer that question, feel free to also briefly introduce yourself.
Yeah, thanks for having us today. I'm excited to be here. Yeah, my name's Jeremy Berman. I'm a VP of Quality Documentation Education at WelbeHealth, and I'm a physician by background and been worked very closely with the medical practice side as well as technology, analytics, informatics. Play a lot of different roles here at Welbe. The book I've recommended most over the years is the Tennis Partner by Abraham Varghese, who's one of the great physician writers of our time. And yeah, it's a great story about the relationship between sort of physician mentor and med student, resident, mentee. It's close to my heart, given some of my background and experience, but yeah, it's just a really beautiful story of their relationship.
Nice. I'll definitely check it out. What about you, Girish?
Hi, yeah, and thank you for having us. I'm very excited about this opportunity. Hi, everyone. I'm Girish Shetty. I'm the Vice President of Technology at WelbeHealth. I have the privilege of leading our engineering and architecture teams. I've been with Welbe for 2 years now, and I have to say it's been the most exciting and rewarding phase of my career. I'm not much of a book reader, but the two books that I've recommended most are Unleash the Power Within by Tony Robbins and Principles by Ray Dalio. Both of them have made a big impact on my approach on personal growth and leadership.
I think you should talk to Thomas after this because he's also a big Principal fan. So you have many things to talk about.
Well, I actually started reading I think it's called The Fund, which highlights the other side of the principles. I'm a little bit less of a fan, or I read principles differently. So I
Oh,
definitely recommend reading The Fund.
I will check that out. Yeah.
We as humans, we always look for things that confirm our biases, but it's really good to actually hunt for things that invalidate some of the things that we think are true, and that's a great book. Yeah.
Will do. Thank you.
All right. I think we have quite a lot of people in the room right now. So maybe Thomas, can you briefly introduce yourself and then let's jump into the first question.
Yeah, Thomas, co-founder, CEO at AWell, and together with Rick, co-author at CareOps. Great to see everybody. I'm excited.
Yes. And I'm Rick, RN by training, co-author of CareOps, and currently product lead at Sort Health, where I built a lot of AI technology for our internal teams. Maybe first question to you, Jeremy. I will start with you, and then Girish, you can add some more color after that. So two questions in one. Like one, obviously, Wellbe is focused on pace. Can you high level explain to the audience what pace is? Maybe explain it like we're like 10 years old, because I do not know that pace is like pretty difficult to understand. So like the high level would be ideal. And then as you go into your explanation, obviously pace means that you serve very diverse populations with very complex needs. So how do you as a clinical leader adapt your workflows or care flows to account for all of these population differences?
Yeah, great questions, and I would love to just spend a couple minutes describing PACE because I think likely a lot of the audience is not that familiar with what PACE does. So yeah, PACE is really more than a healthcare program. It's a lifeline for many of the PACE participants. We call the PACE world, we call patients participants, and so you'll hear Girish and I refer to patients as participants for the rest of the talk. But it really is a lifeline. It is It's truly integrated, high touch, wraparound, medical and social services model that is geared for kind of the highest risk, most frail and vulnerable seniors. And WelbeHealth is an operator of PACE. So there are different operators around the country. WelbeHealth has been growing and scaling PACE centers and PACE programs faster than any other PACE program around the country. And you know, WelbeHealth's mission is pretty straightforward. Number one, it's to improve the quality and the life of our participants. It's to ensure that the care that we're providing them is the care that they want. And then making sure that they can live in their community and live safely at home. And that is one of the eligibility criteria of becoming a PACE participant is among others, but they have to be living in their home and they have to be safely living in their home. Other criteria to become a PACE participant, you have to be at least 55 years or older, and you have to be eligible for nursing home care based on your requirements around activities of daily living. So we're talking about a very, very complex, frail population. Most participants who are enrolling with PACE are have either Medicaid or are dual eligible for Medicare and Medicaid. So PACE is a national program, but both at the Medicare level as well as the state level. WelbeHealth and PACE is an incredibly complex model. We are the primary care providers for all of our participants, but we also have an incredibly thoughtful and diverse interdisciplinary team, and the IDT is really the heart of our model. And we'll talk a lot about the IDT over the course of our talk today. So the primary care is really driving the management of the chronic and acute conditions of our population, and the IDT is wrapping around the participant in many different ways. And the IDT, I've worked in value-based care now for 9 years, and a lot of our operations and clinical leaders and executives have come from a variety of value-based care environments. And I think all of us can attest to the fact that PACE, the IDT, is very different than a traditional IDT. There's the traditional members of IDT. So you have PCP, social work, case managers, pharmacists, dietitians, behavioral health, typically. Those are like the traditional roles of an IDT, but PACE is different. PACE also has all of those roles, but it also has coordinators for engagement, coordinators for an IDT coordinator. It has every participant has access to a driver, transportation services, and they are part of the IDT and just as important member of the IDT as the primary care provider. Because we're providing transportation for all of our participants to any internal WellBe appointment or any external specialist appointment. So we're doing really the coordination across the entire continuum of their healthcare, whether that's coming in to receive primary care in our centers or driving them, not just driving, but actually scheduling the appointments. We schedule all appointments for participants, both internal and external. And then we make sure they get to the appointment. And then once they're at the appointment, we make sure the appointment happens. We make sure that whatever the cardiologist has recommended gets taken care of, gets effectuated. So we're really like, I think of ourselves as not just the quarterback, but the quarterback and the offensive line of our participants' healthcare.
And
yeah.
and maybe obviously this again is a testament of like the complexity that you need to deal with, and also is the complexity of the coordination piece. So how do you then define like care flows, which are like oftentimes like standardized SOPs or whatever you want to call it internally? Because every patient is unique, everyone has different needs. So like, how do you do that from a clinical lens? And maybe then, Girish, we can also talk about it from a technical lens as well.
Sorry. So before we go there, I think for the audience, what could clarify further is how does PACE differ from traditional MA plans? And how does the model then how that impacts your model? And I think then definitely we can go into the the care flows.
Yeah. Yeah, I think it can sometimes get compared to MA plans or sometimes D-SNP plans more specifically, but I think PACE is way more intensive, way more broad. You know, when we talk about you know, I think MA plans are the payer, and we have that in common in that we are a provider as well as a payer. But you know, we have a population health model where we are seeing some of our participants based on the, and I think this gets to your question too, Rick, is we're evaluating every participant in a unique way, and everyone is sort of risk stratified into high, medium, low bucket, which really determines the cadence of visits, determines how many resources we are providing to the participant. And we provide home care as well. So we don't just believe in sort of the four walls of our centers and our clinics, but we go to the home, we have home care, we have home health nurses. And I think one thing we're doing very, very well is addressing the social determinants of health. I mean, PACE has been talking about social determinants of health before it was even a term. PACE has been around for 50 years, and it was really created to address a lot of the social isolation that was happening within the senior community. And so, unlike MA programs, we are bringing these participants to our day centers. Some are coming every day, some are coming a couple days a week. Our day centers sit in the same building, and you can see behind me, this is one of our centers. So participants come to our day centers to get warm meals, to socialize with other participants and staff member. And literally the clinic is housed within the same four walls. Our rehab specialist, our PT and OT, is right down the hallway from our clinic, which is right down the hallway from where our participants get breakfast and lunch. And so it's a really, you know, end-to-end model. Unlike MA, we are sort of responsible for managing participants throughout the continuum, whether they're in the hospital or they're in a SNF. Yeah, we have really robust transitions of care programs. So I think in some ways we can get compared to MA, but I think when you break it down, all the components of a PACE are quite different than what a traditional MA plan or even a D-SNP plan would provide.
Great, thanks.
I think, sorry, go ahead.
No, I think maybe that's is a good segue. So Jeremy did an excellent job explaining the complexities that the care team needs to deal with, which obviously means that from a technology perspective, the easier you can make providing care from a technology perspective, the better, because that's essentially how you can scale this model, because otherwise it will be extremely expensive and extremely difficult. So how have you approached, like from a technology perspective, like what's the technology powering all of this complexity? Can you maybe talk a bit more about that, Girish?
So, you know, as Jeremy mentioned, right, our whole PACE model is we serve a very diverse and complex population with who have these complex health and social needs. So we have to adapt our care flows by incorporating these personalized and patient-centered approaches. So this involves first closely collaborating with our care teams, and then we use data-driven insights to tailor our care plans, promote flexibility in care delivery, and ensure that every participant receives that appropriate care the way they want it. So the care planning, the whole design of the care operations is technology is very closely involved very early in the stage. And whatever the whole care operations happens with technology supporting it and enabling it. So whether it's a chronic disease management, mental health support, or social services, it's all embedded in the technology that we've built. The technology stack that we have is a combination of, an EHR. Athena is our EHR. We have multiple SaaS products that support us. We have a data warehousing platform that collects all the data for us. And then we have the foundation of all is an interoperable layer that is our custom built. And we have a custom care management platform that supports us too. We have a highly configurable interoperable middle layer that drives all this, and all the enhanced reporting and state-of-the-art reporting that we have ongoing is supported by that interoperable layer.
Yeah, and I would add that PACE is so complicated and such a robust model that EMRs, off-the-shelf EMRs, Epic, Cerners of the world are not built for PACE. They're built for a fee-for-service environment. And so Girish's team does an incredible job and partners with the clinical team and the operations team to sort of layer throughout Athena, which is our EMR, to layer throughout Athena a care management program, like he mentioned, that allows us to meet the needs of PACE because Athena just by itself they're not a PACE program. And so we build a lot of nuances with the technology to support the care planning, to support the effectuation of care, which is sort of the delivery and sort of the receipt of the care that either we say we're going to provide or a cardiologist or a pulmonologist says that they're going to provide. All of that needs to be tracked, and we need to make sure that these things do happen.
So coming back to something you said earlier, so the risk score is core to your model. Can you walk us through a really concrete example of, someone's risk score changes and how is that propagated through these different systems and what is triggered and who sees that and what is automated and what needs to be done by the team?
Yeah, it's a great question. So we call it our risk stratification, not to be confused with the HCC risk score. But our risk stratification model, we divide it into low, medium, high, or red, yellow, green. And our IDT assigns the risk stratification based on their assessment of the participant. That risk stratification then does drive the cadence of how often we see them. So primary care visit is going to be 1 to 2 times per month for our highest risk, but oftentimes more if the need is there. Our nurse care managers are involved, at least sometimes weekly for the red risk stratification participants. The number of IDT disciplines that are playing a role within the red participants is very high. The dietitians, the pharmacists, but we also layer in and have a really great analytics team at Welbe that layers in sort of objective clinical data from the EMR, sort of from structured data fields, also from claims history to create a data-driven risk stratification score. Similar, it's going to be low, medium, high, but this is driven entirely by the data. And the data doesn't assign the participant their risk strat. The IDT still drives that because at the end of the day, PACE is a human model and we want the humans assigning the risk score. But the data-driven acuity is really important. And sometimes the data-driven acuity is telling us things about their complexity that our care teams might be missing. And so one interesting thing you can do with when you have data-driven acuity and you have assigned acuity sort of by the IDT is you can compare the two. And where are there big mismatches? Where is the sort of low acuity assigned by the IDT, but the data is saying this is a high acuity participant? Somebody's wrong. And so we got to take a look at those big mismatches and determine, maybe the IDT is correct. This actually on paper looks like a much sicker participant than they are in real life. But we're using data and analytics in other interesting ways as well. We're starting to put together sort of day center prioritization. So I was talking about the day center as a place where people come, receive social outlets and social programming. And we want to know who would benefit most from the day center. And right now it's purely Gestalt and based on IDT input, but we want to support them in their decision making around, are we recommending 5 days a week? Are we recommending 1 day a week? And so we're creating a data-driven clinical and social day center risk score or day center prioritization to say, based on these inputs, based on we screen all participants for social isolation and social connectiveness. We screen all of our participants for cognitive impairment, for what is their functional status. So we have a lot of this data, and we think that people who are very lonely and very isolated, who have a lot of functional decline, and who have some cognitive impairment, those are perfect people to come to our center every day and socialize them, provide them with meals. And so we're creating sort of these data-driven scores to say to the care team, hey, this may be a participant that may benefit from more days in the center per week than fewer. Again, it comes down to the human recommendation, but it's a way to inform the care team about some things that may not be super visible within the EMR.
Great. Just one follow-up question here. So as I understand it, your IDT does not get to see this data-driven stratification.
They do. It's built into our it's built into this kind of layered program that Girish was talking about, kind of our care management program. So they can see what has been assigned, like in an actual color, and then you can, right next to it is sort of what's the data telling us, and why is the data telling us that?
Yeah.
And the automation piece, Thomas, to your original question, is like our lake house architecture support it does is it collects all the data from all these sources. Then we we process that data, and we have a data model that drives that, and then we have an intelligence layer that sits on top of it that is highly configurable, based which we can make and adapt and change. And based on that data is then presented in a format which everyone can consume across applications. So now our care management platform can pull that up. And tomorrow, if we decide, oh, we need to make some changes on how we stratify a participant or what are the key indicators that we need to tune, we can go back and change that on the configuration piece of it, and it automatically updates for every.
And so on the tech stack side, Girish, so you mentioned that you have Athena and then you have your homegrown care management application. Can you explain which profile works in which system and in what use cases? So for example, do the doctors work in both systems, or how does that work?
Most of the doctors, they work in the EMR, they are in Athena, and
Okay.
we have found creative ways to show pieces, and then there is our custom care management platform. We've found creative ways to show things that are relevant and present that data in Athena to them in creative ways through our custom care management platform. And then the IDT predominantly, they reside in the care management platform, and they spend majority of their time doing all the work in there.
Okay. So let's talk a bit about scaling, because complexity and scale are often diametrically opposed. So you expanded the number of locations pretty quickly. Talk us through this. Is it just turning on, opening the doors, or is it a bit more convoluted than that?
Yeah, I think starting PACE programs is probably the hardest thing in healthcare, I would say. But it's interesting if you go back to the origins of WelbeHealth. It was founded by physicians, and I think they were recognizing that perhaps the greatest challenge, healthcare challenge in our country, was that isolated, vulnerable, and frail seniors were sort of receiving healthcare in all the wrong ways and having substandard outcomes. And so they saw PACE as a way to bring a solution to that problem. And I think from the very beginning, the idea was, let's create PACE, let's scale PACE to as many people as possible. And so that's been the mission since the beginning. And since then, we have continued to grow very, very rapidly at a faster clip than any other PACE program has in the last 50 years. But like you said, that standardization is really important. And when you build a PACE program, it's very capital intensive. It takes a lot of time. The application process can be years. Like we were looking 3 years out for where we're going to go next. And so we're a public benefit company, which has allowed us to really invest resources in growing PACE programs in the most underserved communities. And that's really been one of the mission tenets from the early days of the organization. But I would say we're really good at growing PACE. We're really good at standardizing and creating these new centers. We have a playbook. We have a performance excellence team that is a central sort of shared services at WellBe that thinks about how do you standardize both the clinical and the operational model. We have a role we call the TADA role, which is the training and adoption specialist. So it's a role-based central level role that can roll out changes across the organization, but can really help onboard and train new centers that are opening up. We have an implementation team. This is a dedicated team of nurses, physicians, clinical and operational leaders that can swoop into a new center for 2 or 3 months. When the doors open and we start enrolling participants, they can see them and take care of them and provide care, and then also train the new staff that are coming in. And then 2 to 3 months later, they can move out and wait for the next center to open up. And I would say, lastly, this is the only thing that WelbeHealth does. We don't do other things. We just do PACE. And I think if you look across the country of PACE programs, it's often an appendage of a large health system, a large hospital, or a federally qualified health center, FQHC. It's usually an appendage of one of those programs and can often be just an afterthought when you have an enormous P&L. And so WelbeHealth is 100% exclusively focused on PACE. We're not distracted by anything but PACE. And so I think because of that, we're just really laser focused to make sure that we're scaling with care and intention, and we're scaling at the right speed, to make sure that the quality is always there.
And I think another big, adding to everything what Jeremy mentioned, I think another big piece of our secret sauce is marrying this high-tech enablement with true high-touch care. So, technology and data-driven insights are being very crucial to increase and scale our model efficiently and while maintaining the efficiencies across all these sites. So that's another big piece of it. So that has driven standardization of some of our key processes. It really allows us to drive some consistent evidence-based care across all our sectors.
And can you maybe give a practical example? Because indeed, like if you want to scale, you need to automate, but then the complexities of PACE, like it's difficult to automate. Like what are some of the things that you manage successfully to scale from a technology perspective, and what are the things that you are not trying to scale at all with technology because it's nearly impossible?
So I think one quick example I can give is like, for example, the whole aspect of creation of in PACE, every participant when they join, we have to create a care plan, and then we have to the IDT team works on that care plan, and then every 6 months they review the care plan and make updates based on the condition of the participant. So the entire aspect of the creation of the care plan and then the updates that need to happen around that, we've automated that whole workflow through our care management platform, and then that automatically syncs with the other applications around all the things that are tied to that care plan. So if there are things that needs to happen with our EMR, the care management platform will send that information to the EMR for the provider to know, okay, these are the things that we need to update. And accordingly, if there were appointments that need to be set up, that gets propagated accordingly to the logistics platform.
Yeah. So is there a need at all between standardization on the one side and then allowing for autonomy per center? Or is it just, everybody follows literally the same? You mentioned playbook, Jeremy. So I assume there's a playbook to start up a center, and then from that point onwards, is it the same, like truly standardized or not?
Yeah, I mean, I would say we sort of apply the 80-20 rule. I think healthcare is local at the end of the day, and so we create sort of like 80% standardization, and the performance excellence team, the clinical team, analytics all sort of supports that. Because I think people want that. PACE is complicated, so they want guidance on how to do this well. But at the same time, you know, we really prioritize like good leadership. Like I mentioned, a lot of our leaders are coming from other value-based care environments. If you look at our leaders, they've all been at Oak Street, ChenMed, Iora, Landmarks, and other PACE programs. And so they know how to run a market, and the clinical leaders know how to manage a medical practice. And so we want them to feel empowered to be able to do that. And there are, you know, unique characteristics of each market. Take, for example, we have, we have centers in LA, but some of our markets or centers in parts of LA were really impacted by the LA fires a few months ago. And so that was an incredibly local response. I mean, there was a lot of central support. We had a whole incident command center, but that response was driven locally by every single individual and the centers impacted. And we had a lot of participants impacted by those fires. I think one example of how we think about this is sort of, in our medical director meeting that we have every week, we rotate through where the medical directors are presenting some of their KPIs that are that are on our clinical operational dashboard, as a way to sort of share with the team, the broader team, like this is an area that we're having challenges with locally, and that the standard playbook has not helped them. And so what are they doing about it? What is their remediation plan to improve X, Y, or Z? And we want them to feel empowered to do that. And that plan that they're coming up with, that solution, that may end up being helpful for other medical directors on the call, who are having some unique local challenges that may be similar. So yeah, I think it does come down to creating like a good standardization playbook, but also letting and empowering the local leaders to sort of operate their model within the confines of like local challenges.
That makes sense. And then how does the localization, Girish, how does the product account for that, and how does these requests get to you? Is it like
So
every leader can get to you and they can ask like, hey, build me this or build me that, or like how do you create a roadmap based on those differences?
So a lot of times it depends on the change. How we have fundamentally designed our system is we like to call it feature flags, where we could implement small features respective, which is tied to a center, and we can flip the flag and we can align it, add it to more centers, and a lot of it is then goes back to the data collection aspect of it. So when these centers are making these changes, it goes back to that data is collected at the central repository that we have, and based on that we are able to report on that to say, okay, based on the changes you have made, this is the impact that's happening on our end. From a change management perspective, if it is something that is broader that will impact the larger flow, then it has to be brought back through our intake process to see, okay, is this a change we want to make across all the centers at a broader scale?
What is the cycle of these changes that you typically promise to the business, or what can I expect if I'm a part of an IDT or a provider at WelbeHealth?
So we have a very solid product roadmap, and it goes with that. And then we have a very we have an intake process. So anyone can come in and submit that intake through the intake process. And depending on the change, it comes through a prioritization process where we have an interdisciplinary team from across, like we have clinical, business, operations, and compliance leaders part of that, and then we make a decision. If a change is really small and we see the business value tied to it, then we just absorb it, and there's a very quick turnaround to that. We do follow the whole DevSecOps aspect of it from an engineering delivery perspective. But then if the change is big, then it goes through further scrutiny. It goes through, financial review and all that stuff, whether we should be taking it up. And is it really aligned with our organizational goal? Because we have a product and roadmap that we are driving, which is tied to our organizational goals. And are we pivoting for that? So we have checks and balances to ensure that we are aligned there.
Yeah, I would just follow that up to say that we are building fast and changing quickly. And so I think we have become much more intentional over the last 6 to 12 months about how we roll out those changes to make sure that there's the right amount of change, but not creating too much, change fatigue and making sure that the change is, adopted and well accepted. And so we do run pilots fairly regularly to make sure that we can sort of go back to the drawing board before we roll it out more broadly.
Is that part of the standard approach to run a pilot? Can you walk us through practically how you run change management?
Sure. So most of the times, it depends, again, it depends on the size of the change. When I say size, it's more around the impact pieces of it. It could be a very small change of just a configuration, but if it's huge from an impact perspective, we would first pilot it either into a small user group or a center. Most of the times our pilots are across centers, and we have that built in our design where we can do that. So once a change is implemented, we first test it out in our lower environments. And when we are doing the testing, the actual end users are part of the user acceptance testing. In fact, the actual end users are part of the UI design process as well. So they come in, they look at it, they get feedback, then they're part of the user acceptance testing. They test, they give feedback, we adapt, we make changes. Once that change is ready and we have the sign off to say, okay, this is good, it goes through change management, change control. Once it goes through change control, we implement it in the first center. Before going to the implementing in the first pilot center, we also have alignment around metrics and this alignment is again across cross-functional teams. And then once we implement there, we start tracking those metrics. Based on that metrics, we adapt and we say, okay, there are changes that needs to happen from a product perspective where we make enhancements, add features to support it. Or we say, oh, you know what, we may also have to make changes to our process. And we've done this in the past where we not only had to change or make enhancements to product features, but we also had to make changes to our processes as well, because that's what it made sense. And then we again pilot, and if it's too complex, then we'll go with adding just one more center and not just go full rollout. And then again, collect data. So our whole process is very iterative, very agile, and that's a very foundational of everything we do. Not just from a tech delivery perspective, we are very agile, even from a process perspective, where we are constantly evolving and seeing how can we get better. So major initiatives are followed up with lessons learned, sprint reviews, how well are we doing and what are the things that we can do to get better.
And so you talk about data, and as you know, like given the payer and provider dynamic that comes with PACE, what's your framework on like the ROI? Because you can collect a lot of data and some of it is valuable, some of that is not very valuable. So what are like the WelbeHealth's leading and lagging indicators?
Yeah, that's a great question. Yeah, I think from standpoint of ROI, great thing about PACE is if you take care of the participant in the best possible way and provide the best outcomes for the participant, the ROI is always there. And so to your point, I think around leading indicators, we are trying to get as far upstream as possible with our participants to understand them as well as we can so that we can really provide the best level of care. So yeah, some of our leading indicators are going to be around some of the sort of utilization rates, some of our referral rates. Where are we referring to? an example of how we use that, would be like an example is around our podiatry referral. So we noticed in the data, the leading indicator was showing that we were sending a lot of our nail trimming cases to podiatry. So we've stood up, a training program at WellBe to really up level our nurses, our PCPs on basic nail trimming. And now that we're starting to implement this, we're starting to see fewer referrals for sort of that basic nail trim. Another example, readmission rates. So we notice in the data that our readmission rates, when readmissions do occur back to the hospital, those readmissions are happening very frequently within the first 48 hours. So within 30-day readmissions, a lot are happening within those first 48 hours, and we're very, very good at seeing participants after they come home from the hospital within a week. We're very, very good at that. Almost everybody gets seen within a week of when they come home. But we've never really prioritized that first 24 hours or that first 48 hours. And so we've now rolled out a program where we have a home health team. We have a home health nursing team that is already their WellBe staff. They're already doing home-based nursing activities. And so now we're utilizing them as a resource to make sure that we're following up with our participants within 24 hours on the weekends if needed. And we look at the KPIs like 48-hour in-person, in the home visit by our home health nursing staff. That is a really important sort of leading indicator for us that if we can achieve a high rate of those visits, we know they're going to be able to do a home safety check. We know they can check their meds. Do they have the right follow-up plan? What are their vital signs? These are nurses, so they can do assessments. They can triage and escalate things to our provider of the day. They can bring them in, call our transportation driver to come pick them up, bring them into the clinic if they need to be seen by one of our primary care providers, or we can go send a primary care provider to the home. We do mobile house calls from our PCPs as well. Some of our markets have 1 day a week where they're just in the home. So those are things we think about. We have a lot of different sort of leading lagging indicator KPIs that we think about, but those are some examples of how we utilize them.
I guess there's not a single number that you look at every day, but what are, when you start your day, what are the couple of key numbers that you want your teams to see and interpret?
Yeah, it's a great question. We have had over the years, we've had a lot of different dashboards. They were originally Excel spreadsheets, and we got more sophisticated and moved it into Power BI. But then there were 10 different Power BI reports that we were wanting all of the physician leaders and all of the operational leaders to go to every day to look at all these key metrics. So about a year ago, we partnered with analytics, or a small group of us, to design sort of a landing place, a Power BI dashboard that would be the day in, day out dashboard for executive directors and medical directors, for our market leaders. And we organized them by care, either a care process, like care plan completion rates, or another one would be like the risk strat adherence rate. So if we say we are going to see our highest risk participant 2 days per month, what is the rate across all red participants? What's the rate in which we're seeing them? We want to be at the cadence or above. Those are care process measures. We look at care outcome measures like admissions per thousand, ER utilization, SNF length of stay, total number of inpatient admits. As care outcomes would be like, chronic disease management outcomes like A1C control, functional status, evaluation. All of those things are part of this clinical operational dashboard. We have some participant satisfaction on this dashboard. We have documentation, so risk adjustment, CDI related metrics that we want the EDs and MDs to pay close attention to. So this is what we have rolled out. And now I think adoption is really quite uniform across all market leaders. This is their dashboard. And the nice thing about the way we've built that dashboard is every metric has a drill through. So you can drill through your admissions per thousand metric at the market level and at the WelbeHealth level. You can drill through and go to the admits dashboard. And you can see all the people that are sort of creating this metric, or you can look at the CDI metric of address rates. What percent of diagnoses have we evaluated, either accepted or rejected from a risk adjustment standpoint? And you can go drill through who are all those participants, what are all the diagnoses, and what has been accepted and what has been rejected across all of that. So we sort of think about them as like a landing page with subject matter expert dashboards that sort of underlie all of it.
And so, Girish, this is a question for you because you have the market leaders that look at this dashboard, but I assume like as a nurse, you obviously will not look at that dashboard. And as a nurse, I only care about, and this is a different use case, of course. It's like I'm a nurse and I'm going to see Jeremy, my patient, and obviously you collect a lot of information. So how do you make the information that you collect over the years, over the months that you have treated patient Jeremy actionable for that nurse? Is that inside Athena? Is that inside your care management platform? Like, how do you make your data very actionable at point of care is the question that I'm getting into.
Yeah, it's role based. So depending on your role in WellBe and the application where you spend the most time, and then the care flow or operations that is tied to it, we present that data accordingly. So a provider spends a lot of time in Athena. So we find ways, what is the most appropriate and most important information that the provider needs when they are in Athena. Same thing is with ID team members. They spend a lot of time in our custom care management platform. So we work very closely with with our clinical and operations team to say, okay, what is the data, where do they need it, and how do they need it? So, and then there are some cases where there are operational leaders who need data more from tracking KPIs and metrics, and that resides primarily on Power BI as a reporting aspect of it, which could be very specific to their needs. So like there'll be things which the transportation team would be tracking, and the transportation leader would like to review certain things around how are we doing with rides. And that would be a very specific Power BI report that they would be tracking. And certain things which are very more specific to your example, like a nurse or our ID team member, it will be in the application where they spend most of their time.
Quick follow-up question here. So how do you prevent that, given the complexity of the total, IDT team and all of the tasks that need to be done by them, that, several people at the same time are undertaking tasks for the same patient that might be, working against each other?
So
classic example is, somebody's reaching out to the patient for, scheduling a visit with a PCP, and somebody else is, reaching out to the patient to schedule that, nail clipping referral, for example. Does that happen at all? Or have you solved, because this is a classic coordination problem of, where you see multidisciplinary teams with highly complex patients or complex care flows, right? How do you make sure that is,
so yeah, like from a logistics piece of it, we have like there are two pieces of it. One aspect of it is foundationally, how I think your question is more around if someone is updating the same record at the same time, how do you handle that? We handle that like now with tech, it's very easy for us to handle. It's a requirement decision whether do you want to show both of them, like, hey, these both were updated at the same time. Which one do you want to keep? And then more from a scheduling perspective, we have a very we have a central space where the logistic platform allows us to show the scheduling of the participant at the participant's level. So then if someone is doing an appointment, say for podiatry, it's real time. And then at the same time, the one is doing an appointment for a day center visit. It updates real time. So then you can just see it right there at the center, at the system, that when the appointments are happening, those things are updating real time.
But it can happen that two people from the team are trying to reach out to the patient at the same time.
Two people are trying to reach out to the participant at the same time. In the PACE world, it does not happen that often, not at the same time, but we may be reaching out, but that's what we are solving with the care management platform, where we have like an Amazon. It's like, think of it like as an Amazon tracker, right? But for participant care. So it clearly tells everything that's happening with the participant. So when someone is trying to reach out, they know what's going on. So, they will be like, okay, someone has already reached out this participant twice for this care. I don't have to reach out to this participant. So we can see that in our care management platform, and they can drive that. And that's what we are building in the care management platform for them for that to not happen.
Yeah, and I would just add that, on the sort of IDT care planning side, as Girish mentioned, we do these care plans regularly. We update them at minimum every 6 months, unless there's a change in condition. And the care plan is informed by, at least at the initial care plan, after enrollments, informed by every member of the IDT. And there is what's called goal alignment, where all the IDT disciplines sit in a room and they review what are all the care plans that they want to put onto the care plan. And there may be redundancies, to your point. There may be things that the rehab is recommending that are the same things that the primary care is recommending, in which case that becomes one care plan. That becomes one goal for that participant. You don't have duplicates. And then we can track that. We can track effectuation of that care plan at the role level. So we can say, PCP, have they effectuated this particular goal and intervention? And rehab, have they as well? And you can sort of address them differently. And then as the last thing about care plan that we haven't mentioned, and one of the reasons we call participants and not patients, is they are really actively participating in the care that they're receiving. And so all participants have to sign off on the care plan. And if they don't like the care plan, if it doesn't fit with what their wishes and their needs are, it's got to go back to the IDT and it's got to get edited, and then it goes back to the participant. So participants are very involved with their own care. We have our participants, every market has a participant advisory committee where they are contributing ideas and feedback about the care they're getting, about the center, about what the how the day center experience is. So all of these things are important sort of data points that we take back.
There's a question from the audience, is whether WellBe still uses grant pads as part of PACE.
Yes, we use grant pads. Grant pads are one of our sort of participant engagement strategies.
Can you explain to somebody who doesn't know what it is, what a grant pad is?
So grant pad is essentially an iPad. You can take it as a tablet or an iPad, but it's in a very controlled environment. So everything that's built in that grant pad in that tablet is for we can control what they can see and view in that. And so, a lot of it, like, for example, if we want to send an appointment reminder, it would show up in their calendar. There are things they can do, like for like physical therapy exercises. We could send it to them and they could see that, they could review it and do it. They get, like, there's very limited, it's not like a iPad and they can do whatever they want. They can do video calls with that and stuff like that. So it's just a tablet, but in a very closed environment, and it's integrated with our tech stack for usage and how we interact with our participants.
Okay, great. So that's kind of the main interaction channel you have with participants.
Yes, one of them.
Okay.
Given that we have 3 minutes and then we need to unfortunately close off one very short question, and I know that you can answer this question in a very lengthy way as well, but let's try to keep it short and to the point. Like Girish, you mentioned, we have agile baked into the organization in everything that we do. So imagine that I'm an organization that is not agile at all. I'm not used to moving fast. I'm not used to improving. What's like the one or two things that I should tackle tomorrow to become that agile organization in 6 months?
I think it foundationally goes to your mission. Like, if your mission is aligned at the leadership level, then everyone aligns accordingly. So the one thing, it comes with having the right leadership to drive that culture, to say, okay, we are all aligned with our mission as what we want to do. For us, it's like doing what is right and aligning on that. So that the number one thing would be leadership alignment to get that going. And it starts with that shadow of leadership to drive that agile culture. And then obviously there are multiple things that you can do from a process perspective to drive the agile culture. And it's not just, everyone looks at agile just from a technology delivery perspective, but it's more a culture that needs to be driven, and that needs to come from the leadership of the organization.
And Jeremy, same question to you, and then I think we can wrap up. Thank you so much.
Yeah, I think just being very intentional about the goals. I think it's easy to have a lot of ideas and want to change a million different things at once, and all of those individual ideas may be very well intentioned, but I think to be agile, you really have to think about, prioritization of change, what's going to make the biggest impact, what's going to create the most potential abrasion among frontline staff, and just be really thoughtful about it.
Cool, very wise words to end the conversation. Thank you so much for spending 60 minutes of your valuable time with us and with the audience. And thank you for sharing so many interesting things today with us.
Thank you for having us.
Thank you
Thanks.
both.
Thank you.
Thank you. Bye-bye.
Jeremy, bye, Girish.
Thank you.